would request Dr. Sangeeta Gupta to introduce Dr. Geeta Kadayaprath. Dr. Geeta Kadayaprath, welcome.
Thank you, ma'am. Thank you.
Welcome, Dr. Geeta. As we all know that she's a Senior Director of Breast Surgical Oncology and Oncoplastic Surgery at Max Institute of Cancer Care Center. She is Vice President of Oncology Forum Delhi. She is Founder Secretary of Delhi Breast Oncology Group. She is an Executive Member of IASO as well as ABSI. She is Program Director Breast Surgical Oncology Fellowship as well as MEX SLNMB course. She has got many fellowships along with it, and right now she is really very well known as a breast surgeon, and not only among the patients, among our colleagues also, as a very refined and very clean breast surgeon. So we welcome you, Dr. Geeta, for your presentation, and I would like to say that we really need to be obsessed about, we gynecologists need to be obsessed about breast cancer, because we are the only one to which a woman in reproductive years come for the treatment or for any type of help. We know there is a shift of breast cancer from late age to early age. That means it is more coming to the reproductive age group where our role is very well defined. We Indian women, we don't think about our health. If we think that, then we think that we are healthy. Okay? And if we think we are healthy and if we don't have any symptoms, we don't go for any screening. What to talk of screening, we don't want to be aware of it. If we know about self-examination, we self-examine ourselves, but we don't discuss or consult with the doctor what we have examined. So there are so many, and when we see that there is no high risk factor, we are not obese, we don't smoke, we don't drink, we think that we are not going to have the breast cancer. So these are certain myths and certain ignorance in an Indian woman, which make us more conscious. We, the gynecologists, they make us more conscious and should be more obsessed about dealing with early cancer in early age of life. So, Dr. Geeta, you are welcome.
A word about Dr. Geeta. Not only she's a great breast oncosurgeon, she has an interest in oncoplastic surgery also. Yeah, she is very pro for conservative surgery, and that she's a multifaceted personality. Without whatever you have said,
one word from my side.
Every aspect of life she touches, and I think she's a wonderful creative surgeon I have known. And the only passion which I have about it, why should we lose 50% of our patients? Because we see late. Stage 3 and 4 makes me very sad that why our mortality is 50%. The people have an early diagnosis, they live for 2 decades, 2.5 decades, probably they live more longer time than all of us, the people with this. But how to make gynecologists obsessed with the early diagnosis of breast cancer. With that, Doctor, over to you, Dr. Geeta.
Thank you, ma'am. Thank you for your kind words.
Time, not in hurry. You can take your time. We are not in hurry.
Thank you so much.
Harish, you will stay back.
So I have to share screen.
So by the time Dr. Geeta shares her screen, I just wanted to add that she's a great singer as well. But right now,
I
she is really a marvelous singer. And Dr. Geeta, you have a huge task to motivate us all to get our mammographies done as gynecologists. Though we like to motivate our patients, but for our own selves, it's quite a challenge.
Absolutely. So you've set the stage for me. Thank you very much for the... Can you see my screen?
Yes.
So thank you so much for...
Madam, full screen kar lo. Madam, full screen kar lo.
Kar diya, ma'am? Ho gaya? Is it full screen?
No,
not yet.
Ab ho gaya, ma'am? Is it full screen now?
Start.
Okay, so So what I'm going to talk about is breast lump, because that is what is the commonest presentation that comes to you. And as Dr. Sharda Jain said, we have to be obsessed. And, you don't leave that patient alone and say that it is something that you think it is without getting through the problem. So that is what we will focus on. And that is palpable lumps, because palpable lumps are the commonest presenting symptom. And of course, there is nipple discharge, mastalgia and all that. We will not touch those areas. Are you able to see my screen?
Yes, please go ahead.
Yes, ma'am.
Okay. So what I would suggest is, it's a very simple suggestion, and that is that you have to play Sherlock Holmes each time. You have to be very, very meticulous about what you're picking up, because when it comes to you, you should not presume the diagnosis. So it is not that elementary, Dr. Watson, as Sherlock Holmes would like to say. So all efforts should be made to make a clear diagnosis, and the simple mantra is triple assessment. And triple assessment can actually lead you to a diagnosis 99.5% of times. That's a huge number, and it is very, very simple to do. But the trouble starts when we don't pay attention to these three aspects of triple assessment. The first one being clinical assessment, the second being imaging, and the third being pathology.
Just a second, Dr. Geeta, your slides are not moving.
Are they not? Okay, let me
Yes, now we're on the slide. Yeah.
Is it moving?
Yes.
Okay. So let me touch upon, we have to hunt for clues at each stage of the triple assessment, the first being the clinical assessment. So when you talk of palpable lumps, you could pick up something that is benign, but whatever it is, the important thing is to not assume that it is benign. So like I always say, this is something that I think is never going to go out of fashion, and that is a good history and examination. So if you have a templated sheet like this, you will not miss out on anything. I think this holds true for any part of the body. And very important for us is to have a pictorial record. Just make a hand-drawn diagram and put the lump where you feel it is. Even if it is for you, it is important, because then you know what is the area that you're dealing with. And this is a very important piece of information that comes in handy even later during the course of treatment of the patient. So we do know of benign lumps. So, if you see something that big, don't assume that it is malignant. Even benign lumps can be large. They're usually smooth, soft, and you do get this mouse in the breast kind of feeling when it is a fibroadenoma, mobile with well-defined margins. But if you have a large phylloids tumor, you can have a presentation like this. This is not malignant. This could be a large phylloids. You have undulations. You can actually see some visible veins on the surface with some hyperpigmentation.
These are your slides are again not moving.
Not moving?
No. Yes, now it is okay.
तो फिर ऐसे ही रखना पड़ेगा मेरे को लग रहा है. Shall I keep it on this mode itself? Because मेरे को लगता है full screen करने में problem हो रही है. हुआ ही नहीं था. अच्छा, okay. तो मेरे को ही लग रहा था कि full screen है. Okay. So, large phylloids tumor can also present like this. So, even these lumps, you cannot presume these to be malignant. So that is one spectrum of the thing. When you see a benign thing, you think it is malignant. That is one end of the spectrum. The other end is when it is malignant and we presume it to be benign. So you do get these kind of tumors also, which are again, they are non-malignant. And something like this, you would possibly think anybody would want to think that this is an abscess. And we do see situations in which a knife has been run into this and there is no pus that is coming out, because it is not an abscess. This is a malignant phylloids tumor in a young patient. So this is how it will present. Then there is the other situation, which is Paget's disease. And unfortunately, Paget's disease is also something that comes up to us late, primarily because we do not pay too much of attention to what the patient is trying to tell you. So in Paget's disease, what you have is the patient will say there is excoriation, there is a weepy nipple, and in between, after some time, it completely settles down. It's a normal nipple till another episode happens. That's a very, very classical history of Paget's disease. And there have been times when we have biopsied a normal nipple like this in between such episodes of excoriation and weeping, and we've got Paget's disease. So it is important to catch it in this situation, because then it is a stage 0 disease, and as you progress, it can go on to become invasive ductal carcinoma, and it is treated like any other breast cancer. So when we talk of malignant lumps, they're generally firm to hard. It may be a little immobile. There may be some fixity to the surrounding skin and soft tissue. However, don't be under the impression that all mobile lumps are benign. You can get cancers which are mobile or non-fixed. So like I said, most important message in this whole thing is don't assume a diagnosis just by a clinical examination. And you can have things like mastitis, cellulitis. We see it all the time. These are more common, but then it could be a harbinger of an inflammatory breast carcinoma also. So I saw a patient only today. She's got possibly an inflammatory breast carcinoma, but has been looked upon as an inflammatory thing. It's great if it is inflammatory, but the thing is she's got a very strong family history also. So there we should not discount an inflammatory breast carcinoma also. So if you were to look at this, there are two pictures that you can see here. You can see a lot of orange peel-like skin. The nipple is a little retracted. And here you can see a smooth skin. And you can see a little bulge there, which is threatening to burst. So this is an inflammatory carcinoma, and that is a breast abscess. But this is only, but you make sure that it is an abscess by doing an ultrasound of the breast. And then such big abscesses have to be drained. Smaller abscesses can be aspirated. So that is about your clinical examination. The second bit is imaging. Very important to understand in the sequence of things, don't put in a needle first before an imaging has happened. Palpable lesions should always be imaged before a biopsy is done. So we have various modalities, and always think mammogram and ultrasound. Mammogram for those over the age of 40, ultrasound for those under the age of 40, if you're using it as a screening modality. If you're using it for diagnosis, and if you think there is a suspicion, then you would use a sonomammogram or an ultrasound of the breast for those under the age of 30. Helps to distinguish between a solid and a cystic lesion. If there is a nipple discharge, ultrasound is the best investigation, because the nipple areolar area is seen best with an ultrasound, and you can identify an intraductal lesion. If there are lymph nodes, again, ultrasound can tell you whether it looks like an involved node or is it a reactive lymph node by means of the cortical thickness and the hilar preservation. Besides that, an ultrasound is a very important tool in doing a biopsy, and for impalpable lesions to do a wire localization and also to place markers. So if you look at what all you can see in ultrasound, so that is a very, very clear cyst. So cyst is when you have a dark shadow like that, and then you have some enhancement at the back of it. That's the complex cyst, where you have septi within the lesion. So those are benign lesions. The horizontal lie of the lesion should tell you that it is benign. There is no distal shadowing. But if it is malignant, this is what you would see, a very, irregular kind of lesion with a lot of distal shadowing. And when you do a color Doppler, you see red on it. And with the kind of high resolution ultrasounds that we have now, you can even pick up microcalcifications on an ultrasound. So for microcalcifications, the best investigation is a mammogram, but with high resolution ultrasounds, you can see these microcalcifications. So over the age of 30 or older, a mammogram may be performed. But like I said, you get better information after the age of 40, because even between 30 and 40, the breasts are very dense and the mammogram may not give you the kind of information you're looking for. So for calcifications, one of the best investigations. But if you're feeling something and you don't feel that it is right and the mammogram is not showing it up, don't stop there. Please go to the next set of investigations that you can. Especially in younger women, when the breast is very dense, you're likely to miss a lot of cancers. So there you have to understand that the sensitivity of the mammogram goes down. And on mammogram, this is a mammogram lexicon. You don't need to look at it, but essentially we want to know what kind of mass, what kind of architectural distortion, calcification, skin retraction, nipple retraction, all of that can be picked up on the mammogram. So I'll just take you through a few pictures just to give you an idea as to what I'm talking about. So that's a very well-defined lump. That's a benign lesion. And if you look at this, this is what we classically call a spiculated lesion. And you can pick up lymph nodes also on mammogram in the mediolateral view. So if you look at these are calcifications. These are large calcifications. So that's a popcorn calcification. That's benign. So if you see, these are ductal calcifications. Long-standing secretions in the ducts can give rise to these kind of calcifications. This is known, this is possibly an area of fat necrosis because some kind of intervention has happened here. Big pieces of calcium, dystrophic calcification, eggshell calcification, all of these are benign. The trouble starts here where you see this snowy kind of distribution of calcification. That's a very segmental or a triangular form of very, very pleomorphic calcification. So this is in the pattern of the ducts. So that is why these are very pleomorphic and these are suspicious calcifications. So if you look at this mammogram, you can pick up a few things. You can see that the skin is thickened. There is architectural distortion here. There is nipple retraction here. All these could be harbingers of breast cancer. So the next modality, like I said, you're not able to solve the problem with the ultrasound or the mammogram, then you can fall back on the breast MRI. MRI of the breast is never the first investigation in a breast lump. This should be reserved for a problem-solving tool, and it should be done in those places which have a dedicated breast coil and there are experts to read it. If a patient presents only with an axillary nodal lesion and there is nothing that you feel in the breast, then you must get an MRI done because there you can pick up some lesion in about 50% of patients. In Paget's disease, also MRI is the imaging tool of choice because in Paget's you may find foci of invasive carcinomas elsewhere, not just localized to the nipple, but elsewhere in the breast. And for those women who are going to have neoadjuvant chemotherapy, that is chemotherapy prior to surgery, and is keen on breast conservation, then you must do an MRI because we want to assess response and then decide whether she is a suitable candidate for a conservative surgery. So if you look at this patient had a vague lump in the breast, and you can also feel it, but the mammogram is not helping you. So that is where you decide to get an MRI done. So the retroareolar area is sometimes a difficult area. And here you can see an enhancing lesion, which is suspicious. Again, a self-palpated lump, nothing at all on the mammogram. So again, you have to bring in your problem-solving tool. And unfortunately for this patient, what's set off as a unilateral lump, you can see carcinomas on both sides on the MRI. Similarly, dense breast, very dense breast, possibly something here, as can be seen on the mammogram. There you have to use an MRI, and there you can see a very well delineated enhancing lesion. And locally advanced breast cancer, like I said, now breast conservation is not limited only to early breast cancers. You can downsize tumors with chemotherapy, even in larger tumors, like you see in this case. That's the lesion before, and then that's the lesion after the chemotherapy. It is almost disappeared. So what we do is we place a clip after a couple of cycles of chemotherapy, and using that clip, we can go down and dissect that area and conserve the breast. So in post-lumpectomy situations also, you can see that there can be a residual area of enhancement. If there is, then of course you have to advise the patient to undergo a mastectomy. So that is about imaging. And now we come to the third part of triple assessment, and that is pathology. So now we are all so tuned to doing a fine needle aspiration cytology. I've got nothing against it, but with the kind of treatment that we follow now, a core needle biopsy has become mandatory for any lump in the breast. For one, fine needle aspiration cytology only gives you a few cells. It can say benign or malignant cells, but it does not give you any more information. And sometimes a fine needle aspiration can miss a malignancy if it is not been taken from the representative area. So we have shifted from fine needle aspiration cytology to core needle biopsy to radiology assisted biopsy. So we have image guided biopsies now, which can be done under ultrasound guidance or stereotactic guidance, which is on the mammogram machine. This is for accuracy of diagnosis. So that is about the pathology. So these three things have to be done. So let me just run you through a few case scenarios to explain where you can stop at what. So this is a 22-year-old who presents with a painless lump in the left breast, has been static, and you examine and you find there is a mobile lump in the upper outer quadrant. So you've been seeing this girl in the clinic. She comes and she goes. It's been there for some time. So your index of suspicion is low. She's a young lady. She's got a lump which you've been seeing for some time, and this is in all probability in your head is benign. So in that case, get an ultrasound done. And even in her case, don't forget the FNAC if that is what it has to be. So in younger women where your index of suspicion is low, you can get away with a fine needle aspiration cytology. But I will always say that keep your index of suspicion high. So this is a 42-year-old, comes with a painless lump, again a mobile lump in the upper outer quadrant. She's 42 already. So here you would want to do a mammogram. An ultrasound will tell us whether it is a cyst or a solid lesion. So an ultrasound-guided biopsy is done. You get a report like a stromoepithelial lesion, which is a fibroadenoma or a phylloids. So an ultrasound-guided biopsy, mind you, cannot distinguish between a fibroadenoma and a phylloids at times. So we will use this information to operate on this patient, but take margins because phylloids tumor are known to recur if there are not enough margins. Similarly, another patient, 39-year-old, painful lump in the right breast. Look at the duration. It is only 10 days, and she's giving you a history that it is increasing premenstrually. You examine her and you find that her breasts are very nodular and there is a 4-centimeter tender lump in the upper inner quadrant. So here you will proceed with an ultrasound. You won't do a mammogram here because understand that the patient has got a lot of pain. Ultrasound shows that there are multiple cysts and your hunch is absolutely right, that she's possibly got fibrocystic disease, which aggravates premenstrually. And now I come to the final case scenario where this is a 66-year-old now. The moment you see that age, your differential diagnosis does a complete 360 degree. Because here you would be, from the beginning, you would be thinking that I have to rule out cancer. This has been there for 15 days duration. There is no pain, no other significant history. So we do a local examination, and there we find that she has a 2.5 into 2 centimeter retroareolar lump. The axilla is clear clinically, and this is what we see on the triple assessment. So the clinical stage is being staged as T2N0. So we can do either of these tests for diagnostic. Diagnostic would be a mammogram and an ultrasound. Staging, meaning if you do think that on your pathology it comes back as malignant, you would want to know if the disease has traveled to any other organ, for which you may do an ultrasound abdomen, X-ray chest, and a bone scan, and in advanced cases, a PET-CT. For pathological diagnosis, like I said, ultrasound core biopsy of the right breast lump, and an FNAC of the lymph node if it is visible on ultrasound. So this is how the mammogram looks. So you can see that there is a suspicious lesion in the back, and you can see some lymph nodes on the mammogram also. So this is what the patient discussion happened. So we see that her staging investigations are negative. So we discuss all these options. It is very important now to discuss options, and don't say that she's a 66-year-old, so she would not be interested in a breast conservation. We have to have this collateral discussion. We have to have this combined discussion with the patient to decide what is good for her, and this is what she chose. She chose for a wide excision and sentinel lymph node biopsy. And because we were taking away the central quadrant, we did this oncoplasty also. And the adjuvant treatment would be decided on the basis of the final pathology report. So we do something called the sentinel lymph node biopsy, which is a wonderful procedure because this brings down the risk of lymphedema to less than 5%, which is close to 20 to 25% in those who undergo an axillary dissection. So this is the kind of oncoplasty that we did. We removed the nipple areolar complex, but we used the skin and this inferior pedicle to fill up the gap and give her a good cosmesis. So there are similar such procedures like a round block technique. You can barely make out that this patient has had surgery. This is another round block on the left side. And this is a perforator-based oncoplasty, wherein we have used a perforator running down from here and the paddle of skin and fat to fill up the upper outer quadrant defect. And you can barely make out whether this patient has undergone surgery because she gets good cosmesis. For larger lesions, you can also use the latissimus dorsi flap. The right side has undergone surgery. She had a big tumor here and it was filled up with a mini LD. It was a DCIS. So this is my take-home message to you, that you have to play Sherlock Holmes. Think Sherlock Holmes every time you see a patient with breast, because our aim, our collective aim, is to pick up breast cancer early. And as Dr. Sangeeta mentioned, we are seeing patients who are younger. In less than 40, about 15% of our patients are coming with cancer in less than 40, which is about 7% in the West. So important to evaluate all breast complaints thoroughly and very careful assessment of symptoms and look at, like I said, do a very, very thorough inspection, palpation, and the lymph nodes. All of that should be documented. Both positive and negative findings are important. So they can present with a combination of things, but we should keep our ante up and make sure that we see it to its natural conclusion. Diagnostic mammogram over the age of 30 is justified for suspicious lesions, but for screening purposes, not under the age of 40. If there is a negative imaging and you think there is something suspicious, please go ahead to the next level of investigation or refer the patient to the expert. And masses that are solid on ultrasound require a biopsy and not an FNAC, because we need to understand the character of the tumor before we start treatment. And also the sequence of treatment will depend upon the biopsy and the character of the lump. So please keep your index of suspicion high, even for innocuous lump. Be obsessive about seeing it to its natural conclusion. 8 out of 10 times, or possibly even 9 out of 10 times, it will be benign, but we don't want to miss that one single patient who is going to have breast cancer. Thank you very much for your kind attention.
Thank you, Dr. Geeta. Thank you very much for your comments, ma'am, Dr. Sharda Jain, ma'am, and we have a lot of queries too.
I think we will take comments from Dr. Harish here. Dr. Harish.
Yeah, absolutely, Dr. Geeta. It is really, you have covered a very elaborative topic very nicely. The carry-on message is very clear. We need to have a high degree of suspicion that we should not miss them early. We have seen that those we had treated in the early stage are still living after 15 to 16 years. We have all seen as a general surgeon also. And Dr. Geeta has really a passion for evaluating them very early, and best part is for providing it a very good cosmetic care also. And I think this needs to be taken at a very higher level, and it's really amazing and a very good talk. My compliments and congratulations to Dr. Geeta.
Thank you, Dr. Harish. Thank you.
Doctor, my only hump is we see 1.7 lakhs cases. Half of them die. Normally, 13% of us in lifetime are going to have this particular problem. And if we have a breast cancer, and then there is a definitely 3% chances that we are going to die. How are we going to do this? That we pick up the things very early. I think you have made things very, very clear. Never settle down with one thing, that clinical examination. It has to be always combined with imaging and histopathology. This rule of 3 should be followed in each and every case of a lump. And you will never miss a diagnosis. To the tune of 99.5%, you'll be able to make the diagnosis. So I think, this year 2022, we have decided that we are going to work together on cancer cervix as well as on cancer breast. So every 3 months, you have to be prepared that, how you motivate gynecologists that any lump which they see should not ignore it as a benign this thing. So I think with this particular note, we will not take any more comments. I will ask Dr. Sangeeta in case she wants to make any last minute comment. Dr. Sangeeta.
I just want to say that, of course, when lump is there, then we are doing all the things, but we have to be obsessed to detect the lump. Basically, it is the detection of the lump which is missed, and it comes to the later part when the lump is with the problems. So all gynecologists should do a routine breast examination whenever they interact with the patient, whether there is a complaint about the breast lump or there is no complaint about the breast lump. It should be a part and parcel of, before doing a local examination, they should do a breast examination, and it should be written in big words or in big charts that we have to examine the breast of the patient.
I think that's a great idea, ma'am. I think it's a great idea because the number of ladies that you would see, we would possibly never see in our lifetime, because you are the first touch point and you have a great opportunity to, teach them breast self-examination and to examine that. I think it has to be a mandate, which I think it's a brilliant idea.
This has to be an integral part of our examination.
Absolutely. Absolutely.
Dr. Yogesh, you want to make any last minute comment? We will close it at that. You have to unmute yourself.
I would say perfect presentation, Dr. Geeta. I have learned a lot. Of course, I have been out of touch. I don't manage breasts. But it's been...
You have great jobs. You don't have to do breast.
No, but a thoroughly enjoyable presentation. I learned a lot.
Thank you so much.
From now onwards, I would do all these 3 steps and then send over the patient to you. Thank you so much.
I will not lose the opportunity to thank Dr. Yogesh for making me learn how to make presentation way back in early 2000s. So I take this opportunity to thank Dr. Yogesh for making me learn or preparing for me my first presentation on computer. So thanks a lot, Dr. Yogesh.
So at the heartiest thanks on the behalf of DGF to Dr. Geeta and to Dr. Yogesh, and my special thanks to Dr. Harish Gupta for taking out 1.5 hour time for this particular CME. So thank you very much.
Thank you, ma'am. Thank you.
Special thanks once again to Dr. Harish Gupta, sir, and to Dr. Geeta, Dr. Yogesh Agarwal. We've learned so much. Dr. Yogesh Agarwal, really your presentation was so marvelous, so picturesque. And we've seen such lovely, happy faces. We're not going to forget bariatric surgery, and we are definitely going to refer patients to you. Dr. Geeta, you already are one of our icons. And yes, what we've learned from Dr. Sangeeta ma'am is this, that whenever we get a patient for either for pelvic examination, PID, whatever, or we get a patient for ANC as an antenatal case, we must examine the breast. That's one take-home message which we're all going to take. And of course, creating awareness for both bariatric surgery as well as breast cancer. Thank you, Dr. Sharda Jain, ma'am. This is all because of you that we're learning so much. Thank you, everyone.
Thank you, Dr. Sangeeta. Thank you, Dr. Divya. Thank you, ma'am. Thank you.
Thank you. Thank you very much.
Thank you.